Welcome everyone to this today's seminar and session. The title for today is eHealth Readiness. What is it and why is it important? And it's myself, Christine Thomas, and Ella Kolkowska that's going to talk a little bit about this. So my name is Christine Thomas, and I'm a research fellow at the Department of Health, Medicine and Caring Sciences at Linköping University. I finished my PhD in almost 6 years ago now, and my background is behavioral sciences and health psychology. Both my PhD studies and most of my research since has been in the area of implementation science, with a focus on implementing health promotion and mobile phone-based interventions in healthcare. So that's me. And you see a picture at the top there of the building where I have my office. And I added a picture of Örebro's university. And I wasn't sure if it was your building, Ella, but maybe you can tell us.
Yeah, my name is Ella Kolkowska, and I am a professor in information system at Örebro University and at the business school. And my research is about, at least lately, is about development, implementation, and evaluation of welfare technology for elderly. It is usually I have end user perspective in my research. Yeah.
Yes. It's weird in these pandemic times where you get new collaborations that we haven't actually never met. So that's why I didn't know which were buildings. Okay. So our ambition with this seminar is to discuss implementation aspects of eHealth and specifically the concept of eHealth readiness. And in order to give you a broader understanding, we will begin by placing the concept eHealth readiness in an implementation science setting, and specifically the research that has been done on organizational readiness to change. So that's what I will begin to talk about, and then later on Ella will talk about end user perspectives of eHealth readiness. So the content or the plan for today is to cover eHealth readiness and implementation research, what is organizational readiness to change, and what is eHealth readiness, and as I said, end user perspective on these aspects. So one of the challenges with this seminar has been to plan it so it will be valuable for all of you. I realized some of you have a lot of experience and knowledge about implementation, and for some of you this area is a bit more new. So I've tried to have this in mind, so bear with us, and hopefully all of you will have learned something new and feel a bit more inspired in the end of today's session. Just to remind ourselves about what science implementation science is. So almost 15 years ago, implementation science was defined as the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine practice to improve the quality and effectiveness of health services and care. So it's about increasing our knowledge about how and to which extent new interventions are implemented or incorporated in routine practice. And a new intervention in this context can be new work routines, guidelines, or eHealth initiatives, of course. And these interventions can target organization, staff, or patients. So it's a very broad understanding of what intervention is. So that was 15 years ago. And if we look at the different types of theories that are used in implementation science, organizational readiness to change is one, you can say, one of many other theories and models and that try to disentangle what and how implementation is achieved. So it is one of many aspects, you can say, or perspectives that you can take within implementation science. So You see here those orange boxes kind of categorize different types of theories and models, and that have different aims. You can use theory in order to describe determinants of implementation, but also try to understand or explain or predict implementation. But you can also use frameworks and theories to evaluate implementation. So it's a bit different usage, but organization readiness to change is one of many theories in this field. Here you will soon see a logic model that can represent assumption or hypothesis that we often have in implementation and intervention research, actually. So first you have all the well-known determinants of implementation. So we know from theory and empirical research as well that innovation characteristics, how we understand and think about the innovation, the new intervention that's going to be implemented, together with contextual factors and factors among end users and adopters, such as knowledge and attitudes and experience of change, together with how we facilitate the implementation, all influence actual implementation. And then in turn, the quality and the quantity of implementation is believed or hypothesized to result in outcomes on both service and patient levels. So most of us recognize that this logic chain here, where each phase is important to ultimately achieve benefits for our patient and target groups. So typically, you would place readiness to change as a determinant within the implementation context. For example, the readiness of a primary care center to implement a new system for medical journals. Or you can see readiness, or at least the monitoring of readiness, as a strategy to be able to facilitate implementation more effectively. Or we can actually sometimes talk about individual readiness to change, and then it's on these end and adopter level. But in those cases, implementation is more of a maybe individual behavior change rather than an organizational change. But I will come back to these differences a bit later on more. So the concept of eHealth readiness has really emerged partly from the research on organizational readiness for change, defined as organizational members' psychological and behavioral preparedness to implement change. So there is a thought to have a behavioral and a psychological component in being prepared or being ready. For example, being ready to take part today in the seminar would have required behavioral components, of course, like putting the computer on, accepting the invite and so on, but also components feeling interested and motivated to be here and thinking that it's worthwhile. So it's about readiness is about willingness and ability to do something. So we can draw parallels here with behavior change theory that also talks about the willingness and ability to change as being key determinants or predictors of change or behavior. But then it's on an individual level. Here we talk about collective behavior change and the sense of our shared willingness and ability to change in my team, with my work colleagues, or in my organization, or even in the society as well. You can bring it to that level. So let's see what you see here. Here. I don't know why I get to the next picture here. there. So if we stick to organizational readiness to change a bit longer, studies have shown that readiness, what it means and involves or requires, differ on different levels of an organization. So, which is quite logical actually, as most implementation efforts would require different things from different stakeholders at different levels of an organization. So, for instance, it would mean implementation effort would mean differently for the individual practitioner compared to the team or a manager or even policy levels. Research have also shown that readiness is change specific. So it's different depending on what is being implemented, which can be compared to, for instance, the literature on organizational culture or change climate, which would be more stable and general, universal over time. So a healthcare team, for example, can be score high on innovative measures or being very open for change in general, but not necessarily score high on readiness to implement a specific mobile application in their routines for a specific patient group, for example. So it's important to be aware of these differences and what you talk about, what particular change you talk about. Readiness also fluctuates over time, which suggests that to measure or to monitor readiness can be important throughout an implementation process, because it only refers to the readiness to do the next phase or the next stage in the change process, rather than just readiness at the beginning of an implementation process. So here you will see soon a theory called Theory of Organizational Readiness to Change by Weiner. And it's a theory that that is one that incorporates not only the ability but also the willingness among staff members to implement change. So this is what I talked about before, the behavioral and the psychological component. A lot of readiness theories would predominantly include the behavioral or the resources, the capacity to implement change, rather than this theory also brings in the psychological aspect. So the theory says the change valence, which is the belief in the change, if it's perceived to be needed, important and worthwhile, together with an assessment of current resources. So do we know what the change requires? Do we have the resources? Can the change be done given our current situation? These two dimensions together contribute to readiness for change, which is conceptualized as change, commitment, and efficacy. And then this is thought to result in better implementation, both in quantity to the and quality, so fidelity, for instance, you can look at. So the two dimensions of what readiness involves, as I said, is change, commitment, and efficacy, which is shared determination to change and shared sense of collective capability to change. So as I said earlier, the shared aspect is an important difference compared to other behavior change research that has more of an individual focus and the individual's willingness to change. So to shift this up level like this becomes especially important when implementing innovations that are complex and that require more of a collective behavior change and coordinated action. Then it's becomes even more important to look at this shared sense of readiness. So these two dimensions tend to move in the same direction, but they don't do that necessarily. So we've seen that in our own research actually. We looked at the organizational readiness to implement a new care pathway here in Region Östergötland. in primary care. And interviews with physicians and nurses showed that quite clearly a strong commitment or willingness to change. So practitioners believed in this new way of working, that it was in line with their own values and how they wanted to work with elderly. So then this new way of working, there's a picture there of the flow chart. I don't expect you to see the little dots, but it was a new pathway that really riktad äldrevård. A lot of you probably know about this, which was a more of a preventative way of working with the elderly group, and also took a more of a holistic view on health, where you incorporated a multi-professional team and where you monitored elderly health in terms of not only function but also mental health and spiritual health even, and aspects like that. So this new way of health and approaching this patient group was in the interviews quite clearly that the practitioners really valued this, and it was in line with how they wanted to work holistically and preventatively. But the interviews also showed that their shared sense in their shared capability to work in this way, to work preventatively and to work holistically, was poorer, was more limited, because this would require, for instance, collaborate with the municipality and home care nurses, which was and still is, I think, fairly new and has its own challenges and so on, for instance. But to work preventatively requires a different type of resources, which they had misgivings about as well. So in this case, the change commitment and change efficacy did not go in the same direction, which is important then when you're going to implement this type of pathway, to have knowledge about this. So a lot of the things I've talked about, or most of the things, would apply and be relevant when implementing eHealth initiatives in healthcare. But the question is, when we try to implement technology, is there any aspects that are unique for those type of implementation processes? So I haven't been able to find what I think is a good workable definition of eHealth readiness, but you see one here now, which is the preparedness of healthcare institutions or communities for the anticipated change brought by programs related to information and communication technologies. So again, it's about the preparedness to implement something. And here you see a framework that's been developed, a framework of eHealth readiness, and it's in the dietitian practice. I think it's most of the work was done in primary care. So it's based on literature review, but also qualitative interviews and expert panels. And there's a few reviews out there trying to map out what is eHealth readiness and what is unique with eHealth readiness. And here's an example of a framework. There's other frameworks as well. But here they identified 5 key dimensions. So access, the first one, I think, yeah, is about having access to the required technology, hardware, software, mobile applications, and funding, which you think is quite self-explanatory thing to have access to the technology. But in some of our pilot studies that I will talk about in a bit, we've seen that this is not actually necessarily the case. Standards then refers to having protocols and guidelines, regulations, and that type of infrastructure in place to support clinicians and practitioners to use the eHealth initiative. Attitude here is in this framework is quite broad and inclusive and refers to knowledge and again willingness and perceived need of change. Then we have aptitude, which refers to the ability to use an eHealth solution, and advocacy, which these authors highlight or stress as the most important dimension, and it's about ownership, leadership, and the capacity to lead and support eHealth initiatives by engaging stakeholders, and how managers, for instance, communicate the need and urgency for change. So the leaders and managers are seen as the vehicle for eHealth readiness and eHealth implementation. So that's just one example. If you want to read more about the dimensions and these reviews, you can find them in the references in the pictures. I've pasted them in. So to research if and how readiness influence implementation, we need to be able to measure it first. There are research and studies that show that to monitor readiness or increased readiness prior to implementation do actually have a favorable influence or effect on implementation outcomes. So there is an established association between readiness for change and implementation outcome. But more research is definitely needed to see how and to which extent how this relationship looks like. But there are several challenges with trying to measure readiness that I think most of the tools that exist today struggle with. So for instance, the fact that readiness as a concept is change specific. So any tool that measure readiness need to accommodate or acknowledge that aspects that are unique for this particular change. If it's a mobile application we're going to use, or if it's electrical medical journals, or internet-based interventions, or who the target group, all of these aspects will influence the readiness. And also it's important to measure the determinants of readiness rather than to measure readiness rather than the determinants of readiness. So for instance, some of the tools measure more capacity for change. So for instance, what resources are in place to embark on an implementation journey, which is of course important, but readiness is more about how staff members would perceive or appraise this capacity, because that influence how they will act and behave in this implementation. And then how you deal with the readiness is different on different levels. Do you have different tools, or how do you go about to do this? And the role of within group agreement. So if you measure readiness in a team, is it valuable to use some kind of mean score for readiness then? But then you haven't taken into account subgroup differences and so on. In an organization, if you measure readiness in Region Östergötland, for instance, that becomes even more apparent because you have so many subgroups and cultures and so on to consider. So we have attempted to, it's still underway, but me and some colleagues have attempted to develop a measuring tool called eReady. It's a self-help tool that also aims to facilitate the implementation, but also to measure readiness. So we have several pilot studies throughout Sweden at the moment. Okay. So we know that eHealth readiness can involve a range of different interventions that require, of course, both behavioral and psychological components to implement. and that also involve different stakeholders and adopters and so on. So considering what we already know from eHealth readiness and readiness, organizational readiness to change, we can assume that readiness to implement mobile phone-based interventions maybe differ as well for a few reasons. See if I can click this there. Compared with, for example, journal systems or digital journal systems and stuff like eHealth initiatives like that target practitioners or organizations, mHealth interventions often target patient or citizens or clients. So it's a different target group compared to other types of eHealth interventions. But of course, even if you want to, for instance, implement mobile phone-based interventions in Region Östergötland, for instance, it would require commitment from policymakers and managers, as well as individual organizational members and patients. The patients that would be expected to use the app, for example. So mHealth readiness can be different from eHealth readiness. We have done, we're in the process of doing, looking at readiness to implement a mobile application mini-stop that a lot of you know of in primary child health care. Marie Lööf is the lead on that. But there we look at more individual readiness to implement mini-stop, and we've used the Combi model to disentangle that, because it's more on the individual level rather than organizational level. And future studies that we're going to try to look at mHealth readiness and what it involves, what is it, but also how maybe is it different on different organizational levels in healthcare. So we're doing qualitative interview study with policymakers and clinicians and practitioners. So we'll see where this is heading. But talking about mHealth readiness, I think it's important to highlight the end user perspective, of course. So that this is when I hand over to Ella. You have to let me know when I
yeah I will.
Click the pictures.
Yeah, so I will talk about end user perspective, because all or most of my studies is from this perspective. Is the end user is centrum, and it comes from information system field, where we look a lot of user-centered design, for instance, and to look how to involve users in design of technology to achieve values that they that are important for end users, that end users empower end users also in this process in relation to technology providers, and especially in the field I'm in, when end users are elderly people who can change the build. Next slide.
Oh, sorry, it's a bit delayed. You have to be patient. Now.
Yeah, so I could say that my research, I could divide it in three main areas, and it is about end user involvement in development of welfare technology. It's the second part is about evaluation of welfare technology. So I take a starting point in values that different stakeholders want to achieve with the technology, and then evaluate if the values are achieved when the technology is in place. And then I have also study to because it's easy to say values, but sometimes it's not clear what for instance, safety means in relation to welfare technology. What does it, or privacy? What is in this context? So also I looked, and it's also from elderly perspective, value-based objectives that are important for implementation of welfare technology or ICT generally for active and healthy aging. So this is my background, and based off what Christine has tell about implementation, research and studies, and the development of the readiness tool from an organizational perspective. So we have together uh, thought and discussed possible future research or project that when we merge all the competences we have and we look at the tool to measure readiness to adopt welfare technology among seniors or elderly people. So I will give some examples from my previous studies and some lessons learned, what I could see involving users, discussing technology and values related to technology together with elderly users. And elderly, we have defined people older than 65, but most of the participants in my studies are 75 plus. So it's people who maybe don't have experiences of using computers or technologies in the work life. So it's something that they had to learn after they retired. And the technologies, welfare technologies, is some of them are used in health in relation to healthcare professionals, but others are more for use at home and maybe a part of elderly care. So you can, I'm trying to change the build here on my computer, but it's,
I can kind of hear when you want me to change.
Yeah, so end user involvement. I had several different projects here, and it were together with technology providers, and it independently what the product or the technology was aimed to do. So we needed to involve different stakeholders. So for instance, sometimes we work with a technology provider, relatives and elderly people, and sometimes we work together with home care personnel, for instance, or now when we have a project at the dementia care department, then we have different stakeholders. So it depends what is needed in the study. And here are two examples of products or welfare technology. Life Mirror, when we started, so it was just a technology web technology provider had in mind, and it was a mirror that they wanted to use in elderly care, but we didn't have any really ideas how it could be used, what functionality could be included in this technology, what was needed. So it was a mirror that is behind the mirror is a computer screen, and it's placed in the bathroom. So so during the project, and the project was done in elderly dwelling community, they had own apartments, but they also have like common activities. So the people involved in the project were people personnel working at the personal, working with the common areas of this community, which was relatives and it were elderly people. Or so they come up with different possible functionalities. Like you can see that they wanted to have individual messages that they directed only to the users that had this mirror at home, and it could be reminders about appointment or different kind of reminders to take medication and so on. Then they identified a need for group messages that were more related to what happened in the facilities, that they could attend social activities, for instance. And then also they identify a functionality that that increased feeling of safety for the both for the user but also the relative. So every time when the user come in the bathroom in the morning, first time, so a message was sent to a relative that the user is alive, is on and woke up and is and it was a very appreciated functionality. The second one, it was more prototype, and it was communication and safety. So it was used with relatives and users, and the idea was here to be able to easily communicate with relatives or friends. You could have this you could have a picture with names. You just could push the button and very quickly connect with video visual connection. And the other part was more safety related. So the first part was to minimize loneliness and to improve and enhance communication. The other part was more safety related. So it was possible to active and passive alarms. So active, so the user could actively choose to call for help using the button, but it was also used it was an iPad and an iPhone. An iPad was at the end user's home, and it was placed in a place when the user passed several or often during the day. So the passive alarm was that if the iPad couldn't identify any movement in a longer time, it was adjustable for the needs of the end user. So it sent alarm to the relatives that it haven't been movement at home in a time. You can change a slide, Christine. Yeah, so what was focused in this development of this technology was four values, especially. This was usability, usefulness, safety and security, and privacy. So it was the context we wanted to develop the product to ensure achievement of these values, and the end users helped the technology providers to change the products and to change the functionality to be able to achieve the values for the users in use. But what we could see, so it was not only the product itself that and its functionality or interface, but it was other aspects that were also realized in or arised in this tests. Or I forgot to say that all these technologies were tested in at homes during a longer time. We had like 3 or 6 months that the users really could use these products at their home. So besides the product development, so we also could see the problems in technical environments, like for instance, access to internet or access to the mobile network that could make, even if the functionality worked perfectly, so this other aspect could make that, for instance, safety was not achieved because the alarms didn't work because of the mobile not stable or not sufficient mobile network, for instance. Then we also had like things in this physical environment, for instance, where the products or solutions were placed. It could also influence the functionality and achieving of these values, and also the light level of this, for instance, when this iHack product was placed close to the bedroom, so it's disturbed because the light of the iPad disturbed end users to sleep, for instance. And sound level, it was, for instance, that many elderly people couldn't hear the voice from iPad, so the providers needed to strong it by providing other devices. And social environment is maybe interesting here, that we could see that the usefulness, for instance, of these products, it's depended heavily of relatives' involvement in this test. For instance, they if they didn't use this welfare technology, so the elderly was disappointed, and the test was not good. They just didn't use it, so the usefulness was not achieved. But when the relatives were very involved from the beginning and created like a natural way of using this product, and so the end user continued to use the project later on, because they were used to use this way of communication, for instance. They also achieving, for instance, safety and security, even if a product, if a iHack could alarm, could send alarms. So it was important that the network around the end user could receive the alarm, so that it was it's just not just relatives, but it was needed to create a chain of people who responded to the alarms. Also, the end users wanted to have to exchange experiences with other users. It was very important for them to adopt the technology and to use the technology, and a clear guidelines of how to use it. So I think what is maybe related to readiness, that it's not only the product that is important, that it has sufficient functionality and that it works, but also the social aspects around the end user are very important to the user to adapt and use these technologies. You can, Christine, you can change the picture. Yeah, and then value-based or value-driven evaluation on welfare technology. And it's also from end user perspective. Usually or very often when the technology, a welfare technology is implemented, chosen, so it might be driven by economical values or effectiveness. So what I and my colleague wanted to do is to also evaluate other values that are important for different stakeholders, but for the older end user and highlight these values together with effectiveness, for instance, or efficiency of that those solution might result in an organization. So the challenge here is how to measure effects of welfare technology. What aspects should be focused? What even if we identify values that are important, so what these values means for different stakeholders, and how to measure safety and security, for instance, or how to measure privacy, or what does it mean for the different stakeholders. So Christine, you can change the build. So this is one of attempts to see, and this is in relation to a project that was Giraffe Plus, and it was on the previous build, but I can just say it was a robot that enhanced communication between end user. This is the one here in Giraffe Plus. That enhance communication between different stakeholders, and it was relative healthcare professionals, formal caregivers, informal caregivers, and it also was possible to make some measures. So, for instance, like blood pressure and so on, and the measures were sent to health professionals that could react on if it was not in it was some changes, so they could contact end users or send help to home. But what I looked, it was I used ethical value matrix that Nordgren suggested in his publication, and looked. He suggested values that are grouped together in three different areas. It's practical values, that is reliability, easy of use, affordable price. Then we have a quality of life, when we have health, independence, safety, and social contact, and then moral values, autonomy, privacy, and justice. So what I used this value matrix to identify what values were emphasized by these different groups, and it was not so strange. Similar values were emphasized by almost all involved stakeholders. But when we started to look what these values really mean, so we could see huge differences. For instance, for privacy. So for I can say it is a municipality officer, formal caregivers, healthcare professionals, informal caregivers like relatives, elderly people, and system developers. So when we, for instance, could see what people talk about when they talk about privacy, for instance, for system developers, what it was mainly of personal data, while for elderly people, privacy was much broader. It was the monitoring of they at home, how much they want to reveal about their lives, and so on and so on. So here we could see that it's sometimes conflicts between these different understandings and values, and when the different stakeholders are involved, elderly people or seniors usually don't have so much power of a voice. It's not heard, so the consequence might be that the technology that is developed realize values from other stronger stakeholders. So this was one aspect that we looked at. And next slide. And the other challenge is actually how to measure the different kind of values. So here is example from another study that is current, that is still going on, and this is a sensor or digital assistant that is installed in rooms. The people. This study is done in dementia department at institution when have a serve level of dementia, and the problem identified was that they couldn't sleep because they disturbed all the time by personnel who went in the rooms and disturbed, and the consequences were that they were tired during the day. They were feel anxious, and it was a stressful environment at the whole institution. So we decided to implement this sensor or the digital assistant. So the challenge was how we're supposed to measure the effects of this on and what aspects was important to measure. The study is still going on, but what we have identified different stakeholders that are important, and we have identified different areas that we wanted to measure, and then also the measurements parameters that we wanted to use. So to be able to since we cannot interview residents, so we wanted to see how if the implemented solution or technology has an impact on them, and in which way it impacts the health or anxiety and so on. So we try different measures. We combine measurements from the system, like for instance, how many times the carriers enter the room during the night, how much time the residents are outside bed during the night. But we also look at the different quality register, like for instance, BPSD register, and the different dimensions. We looked at it before we implemented the technology, and now we have looked actually after 4 months and the different dimensions, and we can see the clear differences in how, for instance, residents sleep. Or also we look at fall register and medication. So for instance, if we can see if the medication has decreased, for instance, the extra medications that residents can get, for instance, to sleep or to decrease anxiety and so on. So this is what we do for now, and you can put the last slides, Christine. Yeah, this is also examples of how we use. And the last, yeah, this one, please. And the other study. So as I said before, it's not so easy to define what actually people mean with these different values. What does it mean for different stakeholders? And in this study, this part of my research, I look especially at seniors. And what values do they have? What do they think is important in the context of implementing welfare technology for active and healthy aging? And in these studies, I use a method and approach that is called value-focused thinking, and it is defined by Kinney, a special methodology that he says, Kinney, he works in business administration, and he said that when we make decisions, So and create strategies. So usually we take a point of departure in available options. And as he said, it's not a good way to go, because we need to start with something that the important or key stakeholders in the context consider as most important. So this means that all strategies or programs for instance, active and healthy aging implementations should start with values of people that are key stakeholders in this context. So what the methodology says, it's that you start, and there's specific techniques how it could be done. Then it's the values are transformed into value-based objectives, and this is done by inductive categorization to identify the most important objectives in this context. You can change slide, Christine. So we have done this study in Poland, Latvia, and Sweden. So we have identified the value-based objectives that are important for seniors in these different countries. I don't need to show the details. There are a lot of similarities, even if these countries are very different. How the elderly care is provided and the government's role in this, and family role. So even those differences, so many of the identified objectives are similar for seniors in these three countries. And here are some examples, but Christine, you can give next slide. But I also wanted you to see just an example. What do they actually say? What does mean acceptance for them, and what is important to, from the seniors' point of view, what is important for them to be able to accept the technical solutions or welfare technology. You can read by yourselves. I don't need to. Yeah, and this also they highlighted. Yeah, this is a last slide. Thank you. So also how to that it is important for them to increase independence and autonomy, and what they point out as very important in this context. And I could say again, to relate to this to our to the project or to the study that we plan together with Christine and Pietra. So yeah, so this is things that are important for seniors to be able to adopt technology or to adopt the technical solutions. Yeah, so yeah, I this was my last slide. So I thank you for attention.